Good afternoon, everyone. Thank you for joining us. On behalf of the Center for Social and Economic Progress and the Asian Collective for Health Systems, I welcome you all. Uh, the theme for today's webinar is Health Workforce Migration in Asia, Regional Realities, Global Consequences. For those of you who are not aware about TACS, TACS is a regional initiative. It spans across 10 countries in Asia, 4 in South Asia, including India, Sri Lanka, Nepal, Bangladesh, and 6 in Southeast Asia, Vietnam, Singapore, Indonesia, Thailand, Malaysia, and Philippines. In case if you want to know more about TACS and its activities, you can check out our website. Uh, my name is Priyanka. I am a research associate in the health team here at CSEP, and I'm also a member of the TACS. Today's discussion is basically building on one of our recent TACS report. It's a regional consultation paper on international health workforce migration. I'm going to share a link with everyone in case anyone is interested to know more about it. So, we are going to basically take forward the discussion or the deliberations that we have done in this paper. We are going to focus on three key issues particularly. First is what is driving migration patterns beyond individual choices in all these countries and as a region as a whole. Secondly, we would also like to understand what are the health systems, economic, and ethical implications of migration in source as well as destination countries. And the third would be to understand what has been the global, governance response, what countries have been doing, what can we do together as a region. uh, so the format for today's webinar would be we'll have a moderated discussion with all our panelists for 1 hour 15 minutes, which will be followed by a Q&A for 45 minutes. Uh, the attendees can share their questions with us and Dr. Lahiru, who is also going to co-moderate this session with me. We'll be sharing those questions with all the panelists. So now let me introduce our panelists for today's discussion. We have a very rich expert here from Philippines, India, and Sri Lanka. I would like to start with Dr. Johanna Banzon. She is Director of Human Resources Development Bureau at the Department of Health in Philippines. Before this, Dr. Banzon served as the concurrent director for Health Intelligence and Knowledge Innovation Team, which was at the forefront of COVID-19 data analysis and decision support system in Philippines. Dr. Banzon also has some teaching experience. Welcome, Dr. Banzon. We are extremely grateful to have you here with us today. Really looking forward to interacting with you. Many
Good
thanks.
afternoon.
Next, we have Dr. Dr. Professor Saroj. He is professor in the Department of Clinical Medicine at the University of Colombo in Sri Lanka. He is also the founder director of the Medical Education Development and Research Center. Dr. Saroj has multiple research interests in a variety of areas, including clinical teaching, health equity, social determinants of health, application of complexity science to both clinical medicine and population health. A very warm welcome to you, Professor Saroj. Finally, I'm pleased to welcome Dr. Irudaya Rajan. He is chair of International Institute for Migration and Development in India. He's also chair of the World Bank Working Group on Internal Migration and Urbanization. Dr. Rajan was earlier the professor at Center for Development Studies, Trivandrum, Kerala, India. He's also the editor of the annual India Migration Report since 2010, which is a key reference for migration research and policy here in India. Welcome, Dr. Rajan. Thanks a lot for joining us.
Thank you.
I'm co-moderating the session with Dr. Lahiru today. I now invite Dr. Lahiru to kindly introduce himself and, start the session.
Thank you, Priyanka. Thank
Over
you very
to
much
you,
for.
Dr. Lairo.
Thank you. Thank you, Priyanka. Thank you for the kind introduction. I'm Dr. Lahir Kurtoko. I'm the current Public Relations Officer at Sri Lanka Medical Association and also the former Secretary of Sri Lanka Medical Association. It's an honor and privilege to moderate this session with you, Priyanka, with this esteemed panel. I think Priyanka has highlighted some of the housekeeping rules also. So, without much ado, let me start the first round of questions of this important panel. Uh, I think, given the regional and also global importance of this issue, it's important that we highlight some of the trends related to health workforce migration across South Asia and Southeast Asia, because historically these countries have been identified as so-called suppliers to the developed countries in case of health workforce. So let me put a general introductory question to all our esteemed panelists. I think one can answer this question also. What are the current trends in your region, like in South Asia region, specifically mentioning India and Sri Lanka, and also Southeast Asia region, specifically in the context of Philippines? What are the trends that you see now in health workforce migration, particularly in relation to younger generation? Because historically we have seen these migration patterns. Are we seeing any changes in these migration patterns of healthcare workers? What are the trends? Perhaps Dr. Benson, you can answer first. Over to you, ma'am.
Thank you very much. That's a very interesting question. The issue of migration has been recurrent in the past years. But I'd like to say that when we speak of migration in the Philippines, it's not simply uh, migrating from the Philippines to other countries. In fact, one of the trends is that there is the migration from rural to urban places. So that's the first kind. The second one is the migration or the movement from the private sector, and this it might strike you as surprising, but from the private sector to the government sector, the public sector. And why is that happening? It's because the salaries in the government sector for health workers are generally higher than the ones in the profit oriented private facilities. No, the third is the movement from the health sector to other industries. So you have workers moving to BPOs, for example, or for um, uh, the hospitality industry. So we see that migration, besides, of course, the movement from national to international. So that's a first trend that's recurring. We see. The second thing that we've observed in the Philippines is that the countries of destination remain stable or steady. Of the top 10 countries that we have, that we see our health workers traveling to, six of these are in the Middle East. Um, and 6 out of 10, that's 60%. Eh? And then only one in Asia, Southeast Asia, that's Singapore. And then three in the West, but we are speaking only of first-time migrants. So what happens is they go to these countries and they move to the US or the UK. That's the second trend that we've seen. The third trend that's really interesting is that some of the health workers travel as tourists and work on their applications, return home. By then, they will get the acceptance. Then they process uh, their applications. Uh, and the fourth is, and this one is a big topic. We have seen in the Philippines that in relation to the universal healthcare, there are um, four major categories. Four major categories. So we have the health professionals, In the health workforce, we have the health professionals, we have the non-health professionals or the non-professionals in health. Then we have the public health practitioners, and we have the which is often neglected, the health system administrators and managers, right? They're also health workers. And if we look at the composition of the health workforce, we see migration as an issue among health professionals, mostly among health professionals, not so much in the other three quadrants. But I'm going to stop there. I guess that's the trend that we see here in the country. Thank you.
Thank you, Dr. Benson. Thank you. Very interesting trends indeed. Like I was intrigued to hear about the transition from the private sector to government sector, unlike in South Asian countries. Perhaps there are differences, and also the trend towards the Middle Eastern countries from the European countries, which is a very interesting trend. Thank you for highlighting this. I may now go to Professor Rajan. Professor Rajan, any inputs from your end regarding the trends in migration, particularly in a very South Asian context?
Right. I just move from what Benson said. For India, you look at the migration trends as of now on doctors, nurses, or the allied people. We don't have like a statistic like what you have in Sri Lanka, for example. You have only one airport. They do give, a lot of data on the Bureau of Labor and Employment, which I visited recently in Sri Lanka. So I think for India, we are walking in darkness. There is no data currently. Anyone can tell you how many nurses or how many doctors are moving. You get some data from the OECD countries, some data from the Gulf countries, but as a countries of origin, India has failed to produce any decent data on the health professional migration. I think this is something for the future research and future project for people. In fact, I estimated some number several years back for the WHO. I think I saw being quoted up and down, but that was an estimate basically. So I think this is the reality. But as I see my current research, I do research for the Kerala government right now on the Kerala migration survey, as well as I'm doing a project for Indo-Germany migration corridor for the European Union project, which all indicate that there is a huge chunks of young people are leaving India after their medical professions, especially the nurses. And that you can see the infrastructure what you have for the medical profession, it is too low. So we are already seeing not only people are migrating to as a nurses from Kerala, they are migrating to other countries to study nurses and doctors. So we see a large scale Indians even leaving for higher studies to study nurses outside the country. I'm seeing people now going for BSc nursing to Sharjah from India. So you can imagine we are not only send nurses now, we are also sending people to study nurses. But I see this as a what I call them the middle class phenomena in India right now. So I think it will have a long lasting implication. I can talk a little bit about some case studies at later stages, but I just want to tell you that we are walking in darkness. That's why I always make many times when India calls non-resident Indians, we call them NRIs. I call them not required Indians. We never even collect any data on them. They are not required, just to let them go, make some money and send back if they want. Otherwise, they can take their families and go back, which is what happening with especially the health professional migrants. They don't come. They just to make the other way around, So I think I'll stop here, but I will come back with some new ideas in the next, discussions, which is coming back very soon.
Thank you, sir. Thank you. Thank you for highlighting the data scarcity, I think, which is not only for India, I think across Southeast Asia and South Asia, it's a problem when it comes to health workforce migration because the data sets are patchy and not interconnected region-wise as well. So thank you for highlighting that. We can have a discussion on that in the second round. Let me move towards Professor Saroj. Saroj, can you kindly highlight what are the trends in Sri Lanka? Because now we every one of us know that Sri Lanka has gone through a very difficult time economically when you consider the economic landscape of the country. And given the fact that Sri Lanka produce medical professionals through taxpayer money, the free education and the free health, state health service. So given all these issues at the background, what are the trends that we are observing uh, in Sri Lanka regarding the health workforce migration?
So thank you very much. I will try to compare with whatever was said so far. Now, internal migration has always happened. That's from the rural areas to the urban areas. And you see most of the hospitals and stations are in urban areas. But we've got a very good network now. And there are the rural areas are also well serviced, though there are inequities in the doctor-patient ratios and so on. From the government to the private sector, we don't have that as a major problem because we allow almost all categories other than interns and administrators to do private practice. So they're switching between private sector and public sector, augmenting the income which they have for the government sector. But leaving those aside, I think what's really affecting us is this the recent trend of mass exodus of doctors from Sri Lanka, especially from the specialist grades and so on. If I may, I don't know whether I can see. Oh no, I don't think you all can see that. Yeah, publication. There is a recent publication which came out in the International Journal of Health Planning and Management. I was one of the co-authors, and it was by Nirial et al. And we've tried to document and look at the trends. And for examples, they've referenced one paper. You see the type of migration which is affecting us is this highly qualified people who are either trained or have undergoing training who are leaving, right? So, and these are all tax-funded training. So in other words, our taxpayers are subsidizing the taxpayers of these affluent countries, right? For example, in the UK, there were 3,082 doctors, of which mainly 1,700 were non-specialists, right? So you're talking of about 1,200 who are either consultants, 390 consultants, 430 specialty doctors, 429 specialty registrars, and 323 undergoing training. Even if we leave aside all that 323 as undergoing training, you will see we are actually exporting highly qualified, fully qualified people. And that's the worrying trend. The second thing is we are now increasingly seeing nurses and carers going because the markets are opening up. And again, some of the nurses, well-trained nurses, are going as carers, which is very sad. And we are having that sort of migration also. So the trends have increased over the past few years, ever since COVID hit us and the economic crisis. We've had almost an exodus. And in addition to the numbers, qualitatively, there are changes, and we are losing highly specialized people who are leaving the country. Yeah, thank you.
Yeah. Thank you, Professor Saroj. I think you highlighted the multifaceted nature of this issue, I think, like the highly specialized cohort of doctors and also nurses leaving the country and also the caregiver. I think this is also a sort of this is also creating a public discourse, the devaluation of their credentials to a say so forth like inferior category, right? So that we can discuss later. So from the first round of questions, I think it's clear that there are in-country changes of health workforce migration patterns, like from rural to urban, and also Dr. Benson highlighted the migration from the private sector to government sector, which is very interesting. when we compare it to the South Asian context. And also, Professor Ranjan highlighted the data scarcity, and Professor Saroj highlighted the highly specialized categories being taken away from the developed countries once they have done their all training from the taxpayers' money from their source country. So this brings us to the point to us in a broader perspective to see what are the push factors in our individual countries, right? What are the push factors that is enabling these healthcare professionals, be it a doctor, be it a nurse or a caregiver, to move to other countries. We know the traditional push factors from the economic perspectives and so forth. But are there any changes in these push factors that we are seeing from a country perspective? I would first go to Professor Saroj. From a Sri Lankan perspective, sir, are you seeing any sort of new push factors being accounted for this health worker migration?
It's most definitely. And it's very interesting if you really look at the trends. In 1970s, 60s, 70s, we had doctors migrating in large numbers. And that was because there was a change in the language policy and the university admission criteria and so on. But then after that, there was a steady still continuation of migration, but there was no large exodus. And of course, then came the conflict which we had in the north and east of the country, the terrorist conflict. And due to that, there were lots of people from certain ethnic groups, especially the highly specialized and well-trained health workers, especially doctors who are from the Tamil ethnic group, Sri Lankans, they migrated. And quite understandably, it was because of the terrible situations which arise in any conflict. So they did leave in large numbers, and that was from 1983 when we had almost a civil war sort of conflict, because there was what we call Black July. And then after that, we had several periods of people leaving the country. But the current crisis began with the economic downfall, because we became an indebted nation. And we had, again, a huge civil uprising, even though the number who died were very, very small numbers, but we had a huge crisis. And after that, the confidence in the country's stability, I think, was a key factor which led to the exodus of doctors. And with that has started this new trend of people now, even in medical school, some of them wanting to leave the country. They're planning, before their internship, they're now planning to go to one of the Australia, UK. Dubai has become another place. From Dubai, then to go to UK, to New Zealand, and a few to Singapore. So things are now the trend is the reason has been different and mainly economic. We can go into the details of this later, but I think it's mainly economic. Yeah. Thank you.
Yeah, thank you, sir. Thank you. Thank you for highlighting the historical perspective also, and the sort of greater weight that the economic perspective has given to this problem. Next, I will move to Dr. Benson. Dr. Benson, you highlighted some of the very peculiar, in the sense of if you compare with the South Asian perspective, some migratory trends. So in Philippines, are you seeing any new push factors? You highlighted the migration from health to other sectors as well, right? And also the new trend towards the Middle Eastern countries, the healthcare workers are migrating towards Middle Eastern countries also. Are there any new push factors, or are we seeing the same chronic factors that has given rise to this issue?
Thank you. As you've mentioned, the economic factors will always be there, right? But I think so. It's the usual suspects. It's usually economic and job related, so decent working conditions, career related, no opportunities for career growth. But I think the factor that we don't really speak about is um, it's almost like a cycle. There is high demand for Filipino health workers, and this demand drives amazing, huge production of these nurses, and so we are able to send health workers. The health workers are able to migrate to other countries. But one of the results that's not expected is this perception of success that once you've left the country and you've worked abroad or trained abroad, you're a successful health professional. And families who have members who are abroad uh, have arrived, shall we say. And so, this is something that we should be able to recognize. It's not just economic. It's not just the poor health workers coming from the poor families seeking out better opportunities abroad. That's definitely not just it, because there are children of rich families who go to other countries because that's perceived as a measure of success. So that's one that we don't really um, talk about. But the other thing is also better quality of life. Some countries are the destination countries are becoming more and more creative in their recruitment campaigns and messages. And one of these creative ideas is to allow these health workers to bring their families to the countries, and it's a better quality of life to offer a chance to travel, a chance to see snow, and have holidays, skiing holidays. That should not be ignored. The fact that it has much influence on the decision to leave the country. So you have a combination here of push factors where the labor market in the country is not that attractive, and the pull factors where the what is offered in the destination countries is very attractive. The end result is retention that's very challenging, retaining our health workers. I'll stop there. Thank you.
Thank you, Dr. Joanna. Thank you. I think you highlighted a very important perspective, I think, which we are missing in some of our policy development work also. Like, we are always sort of focused on the economic factors and the societal factors rather than the individual factors. The perception about success is like, in a very individual perspective, is very important, I think, when it comes to health workforce migration. Thank you for highlighting that. Professor Ranjan, so in your first round, you mentioned about the non-resident Indians or non-required Indians uh, in your definition. So, how these trends of non-required Indians? What are the push factors that is sort of promoting these people to go abroad, not only for say like the work, and as you highlighted, for education as well. So what are the push factors that you see, particularly in a sort of a state like Kerala, which is regarded as one of the sort of most human development index wise most developed among the other Indian states? What are the push factors that you see?
I think if you look at the push factor compared to the olden days, I would put a new push factor is coming, like return to investment. So somebody want to invest, say, $10,000 for studying nurse. How quick you get that money back? And for the money back, getting money back, if you are in the country, it will take maybe years and years. if you go out, so there is this is something is people now talking about the return to investment. I think this is not the because we did now some studies on nursing colleges in Kerala and Tamil Nadu. Why people are studying nursing? What is motivates for them? Because many of them said their parents were not nursing. Like, sometimes you say the doctor's son become doctor or the police son become police. It's not true now. See, they said that this is something we talked to all the young girls and boys who are studying. Look, came here because this is where we can get our money quickly back, whatever we invest. Second thing, there is a possibility of migration. Because we came to study nursing not because we want to serve the country. We came here to study because to migrate. You see, this was not that much true compared to earlier days. And the third is what they are also suffering is the high recruitment cost for the nursing migration from India. You know that people spend so much money and sometimes they are being cheated. So I talk about the fair recruitment. So I think these are some new challenges coming up. But added to that, country like India compared to Sri Lanka, because I just noticed in Sri Lanka, the latest census has shown to us that you are going to have a negative growth rate. I just got the latest data because I work closely with some institutes in both the demography department and also in the Marga Institute. So I think India is still having a huge demographic dividend. So that's why everybody is coming to India to sign mobility agreements. I don't see, when I was in Sri Lanka a few weeks back, I was talking with the Department of Bureau and Labor and Employment. The migration is there, but not that, because you yourself need people now. Unless you encourage people to come from other countries, I see a lot of Chinese is coming in, but not Chinese nurses anyway. So I think, it's going to be something we are advantageous position now. That's why we can send people to other countries. And the other side, you also have an aging population. So you have a perfect match. You need people, healthcare people, which I saw in Germany, which I'm now looking at the G2G triple win program. I asked the Sri Lankan government, are you doing something on triple win program? Kerala is doing a triple win program, sending nurses directly from Kerala to Germany. But I'm not happy with the program as a researcher working on migration, but that is happening. People are coming up. When I went to Europe, they told me we want to replicate the G2G model to many countries. And also many countries, even in Europe, like Austria is looking at it, Netherlands is looking at it. Can we replicate the G2G triple win program, which some of you might have heard about that? So I think things are changing as Dr. Both Lahiru and other people said, COVID also can change the landscape. You see, COVID has created that. In fact, COVID period, you can imagine many countries who are holding that position to run the show. It is mostly South Asians. So I think it will continue to be, along with the Philippines and Sri Lanka, of course. Kerala is leader in sending nurse migrants. Of course, now India is picking up because Kerala nurses are leaving. So we are also getting nurses from the other states. I think that is not that much true within Sri Lanka, because you are only 35, few districts and people move from north, south a little bit. But Kerala is a huge country. We can get nurses from all states to Kerala, because Kerala is also reasonably, wages are reasonably better. But the nurse wages are very bad. I don't know about Sri Lanka. In India, it is too bad. In fact, the low-skilled workers working in the field will get more salary, more money than the nurses. That's why the return to investment is going to be a biggest topic, and the recruitment cost will be something which we all should look at it for the both skilled migrants, especially on the nursing. I'll stop here.
Yeah, thank you, sir. Thank you for highlighting this return to investment, and also I think the part that when it comes to Sri Lanka, also not unlike Kerala, the aging population within the source countries, I think that will play a big role in the future when it comes to migration, health workforce migration. So uh, with all these inferences, I think we have come to a stage where to sort of examine some of these individual systems very closely. For example, now Sri Lanka sort of has a state-funded education system from kindergarten to the university, and also for postgraduate education, especially when it comes to doctors and nurses for their postgraduate qualifications. Also, the state funds, whereas the Philippines has a well-structured sort of a migration model. So moving forward in future, when you compare Sri Lanka and Philippines, particularly. So, what system creates more threats, right? Sri Lanka has a state-funded sort of a education system and also a recruitment process. Philippines has a well-structured migration model. They do produce the nurses and doctors, but they have a very structured sort of migration model also. So when you compare these, I want to have a sort of a overview. What is creating more issues when you sort of project it to a future? So Professor Saroj, you can start off. I think you can highlight whether
Yeah,
this system that we have in place in Sri Lanka will create more problems for Sri Lankan population in future.
right. I will do that, but I want to bring up a very important issue because this migration discourse is all about trying to see what's happening in the source countries and how well can they get adjusted to the to the new recipient country. In this, we are leaving out the role played by the receiving countries, right? They encourage migration because they want their people to be looked after, health and otherwise. They allow skilled migration so that they will get only the skill. If you're talking of free market, open the market for all labor and we'll give you a good run. No, they will not do that. They will open only for certain skills which they want based on their economic models and based on their predictions. And we are being incentivized to go into those job opportunities. So I think we have to, while we juggle around with the system, I think there has to be at the real top level, of course, we don't have much hope for rule-based world order now with what's happening in the US. But having said that, we should be pushing for some sort of principle and ethic-based migration policies. You see, so having said that, I think the issue for Sri Lanka is the fact that we fund our education using taxpayers' money from kindergarten to A-level to the universities to the postgraduates. Everything is tax funded and hardly anything have we got to pay unless you opt out to get your education in the private sector. I'm a product. I retired as a professor of medicine. Everything was funded by the state, right? I didn't have to pay any fees. So I think we are this sort of model which we have has its disadvantages and advantages because of the free system, and also health is also provided free of charge to the user. So this tends to keep people also because there is some sort of, you haven't really wanting to get back your investment because the state has invested. And so I think that's a sort of a positive aspect which we have from our system. If you compare with the system, I think in Philippines, which is very well, I mean, it's worked out very well, but it's mainly private sector, if I understand what's happening, right? Yeah, thank you. I hope I answered the question, but we'll come back.
Yeah, we can always come back. Yeah, thank you, sir. And also highlighting the perspective of the countries who are sort of getting the advantage. I think that is important. As you said, the discourse is purely sort of focused on the source countries, whereas some of the factors in the countries that getting the advantage, we have to sort of research into that carefully as well. Dr. Benson, if you may sort of highlight how this migration model, which you produce doctors, you have the doctors and nurses for domestic consumption as well. You have a very successful model of sort of giving them opportunities to work overseas. Can you explain a little bit on that? Yeah.
Yes, thank you very much. I know that it is a perception of the global community that the Philippines actually produces for the world. But that is not the case. It has never been the policy of the country, of the state, to send its citizens abroad. Rather, it is a policy of the state to build its economy so that everyone, health workers included, will have a choice. But should the Filipino worker, health worker, decide to work abroad, despite the options here domestically, then the state will protect their rights and welfare. So that's essentially how we've that's the foundation of our migration. We do have the Department of Migrant Work and other agencies that really support Filipinos going abroad, but it was never explicit, deliberate, and articulated policy. Having said that, the intention is really, or maybe I should say the priority is to produce health workers for the domestic needs. But because of aging, because of the trends, no, and the demand for Filipino health workers, the market had to respond. So essentially, but it doesn't have to stop there. It doesn't have to be uh, the, left to the market. We can be, as a global community, actually talk about this and decide how we can actually how some countries like the Philippines can help the needs of other countries, destination countries, but not to the detriment of our health system. For the longest time, it was seen, migration was seen as, oh, something that's good because it helps the individual workers. But the question is, what about the health system? Because while the health workers actually improve the health system in the destination countries, migration has dire effects on the health system. I think the conversation has to be brought there. What then should be done at the global community level so that for countries who are able to help or assist in terms of HRH needs or health workforce needs of other countries, how may they be protected and how may they be supported so that they are able to produce and respond to the needs both domestically and globally. I think the conversation has to go there. Very recently, the Philippines has started to talk with some destination countries and offered our take on this. So we have started to talk about ethical co-investments, for example, and what it actually means. How much does that cost, and what will it cover? But of course, all of this is really ongoing and exploratory, and it's really interesting. But that's where the conversation should be. Thank you.
Thank you, Dr. Vance. Thank you. You highlighted the importance of regional collaboration. I think not only the regional collaboration and also the collaboration between the host country and the source country as well. Thank you. So this brings us to the next stage of our discussion. What are the solutions that we have, right, for this problem? So let me hand over to Priyanka. Priyanka will moderate the next session. And over to you, Priyanka.
Thanks a lot, Dr. Lahiru. It was wonderful to hear from all of you on like what are the problems, and problems are not that simple as we usually hear about a brain drain narrative, but it goes way beyond that. So I would like to understand what are the solutions, what can be done to solve these problems. We can see that there are similar problems across all these three countries, and like together, like India, Philippines, and Sri Lanka, we supply a substantial share of world's migrant health workforce, but we still do not have any strong regional framework to manage this. So why has regional governance remained so weak, and what could realistically change actually? I would like to pose this question to Dr. Rajan first.
Yeah, in fact, I could not, I did not participate in the third question because Lagiru did not ask me the third question. So I will go from the third. So then only I can move to the fourth because there were some missing points. I think one is that we have to discuss, how these rich countries in Europe and Canada are exploiting the poor countries. I think we should something very, very serious on that. Because we put all our money to educate our children, they come and pick them up, like cherry picking, I call them. I think we should think seriously on our migration policies. I think it's very, very important. If you really want to forget about, your sustainable development goals, even a country like Sri Lanka, country like Kerala, you want to sustain your health, forget about improving. Just managing your hospitals, you need people. It's not like forget about sending people. I think there you should talk about encouraging return migration. I would always talk because that's why I am very pleased. Donald Trump, he's sending back people from America to India. I think we should not have somewhere we should talk about encouraging return migrant health professionals. I think this is very, very, because many people, like here, for example, somebody in Sri Lanka and Kerala, they retire government at 55 or 60, then immediately they go into government hospitals, private hospitals, and they pay them maybe huge money than what they were earning as the professors in medical schools. I know that it's happening in Kerala. So I think it is our responsibility to encourage return migration, and maybe because what happened, if you look at it, when I talk to many people, it's all money. Migration means money, and nurse means you have more money. I think this money, in the context, we are also not talking about how it's changing the family structure. I call them the social cost of migration. I have seen how the families are separating. Children are, this is not being discussed. I went to UK and Ireland to study nurse migration. I have seen like house husbands. House husbands. We talk about housewives. Because these women are taking somebody as a husband, they think that they will get a job, and there are a lot of psychological, social stress in the family, children left here in Sri Lanka, in Kerala. So it's, we are sitting on a hotbed, but we are counting remittances. India is number one. I think it's very sad. We never talk about people behind the remittances. I think this is where the policy should come in. I think the policy is very, very important because we are looking at nurse as an individual. It also has some societal responsibility. What Dr. Saroj said. Because it's a social response. It's like somebody studying economics is okay. Somebody studying health, because health is a state subject. Somebody is a health professionals. Of course, they can go. It's like a right to move. We cannot stop anyone to leave Sri Lanka or from India, because I don't think we can do. But can we have policies to encourage them to stay more time in the country? And we can also revise our wage structure in our own country. You see, because why do you have this, wage revision? Because, I don't know, this is true or not. Many times, some of our teachers in many of our places, the teachers in Sri Lanka and India might be working as a housemaids in the Gulf countries, because the housemaid they earn more than the teachers in our own country. So we have to really think, can we think of the wage structure, and can you also talk to the sending countries, in the name of your development, in the name of your health, your wealth, or your life expectancy, you are going to kill our life expectancy, because life expectancy in Kerala and Sri Lanka might come down in the coming years, because you have an aging population and nobody to care. Because nobody to care. Look at the elderly care. It's almost singing in Kerala. I can see that. We call them remote care. Children are migrating. I think it's going to be a very tough task ahead for us, unless you come out of box ideas, not a routine policy. You bring labor policy I've seen in Sri Lanka, or immigration bill we are talking in India for almost now 10 years. I think we have to come back with a reasonably important policy, and also we can promote south-south migration. Why we should send south people to north? Why can't the Filipinos come to Kerala? And why can't the Indians nurses go to Sri Lanka? Why only we have to send them to America? Why? I think we should also, there should be a dialogue on South-South migration. Dialogue should be very important. Why should we only serve to Germany? Why can't we serve to Singapore, or we serve to Nepal? I think that type of policy at the regional level, at the country level, I think we should do that, and we should bring those developed countries to invest on us. They should invest in our country. They are looking for our doctors. Many people in our country, I see that people are learning German languages. We have 600 institutes in Kerala. I asked them, what are they doing? They said, everybody want to go to Germany. I said, somebody will come after 10 years like Donald Trump. There will be a flight will come back from Germany. I think this sudden increase in some countries is going to have a backlash. It also creates a lot of political discourse. Many countries are fighting elections now based on migration, far-right politics, including America. I think so. In that context, emerging in other countries like UK and Canada, Australia, the general migration that also applicable to health migrants, not just general migration. I think we have to think very, very seriously on looking at a good policy to promote migration. At the same time, we should not suffer. Like, I give food to everyone, but at the end, I have nothing in my table. I think this is going to be a serious issue. May not be true right now. You don't see that. But I think Sri Lanka should see that. Kerala should see that. We are seeing that right now. In fact, I was in one of the hospitals in the Kerala government hospital. They need an operation urgently. They have no anesthetist. You can't do any operation without an anesthetist. All anesthetists are migrated. They're all taken leave from government hospital. They are making some money in the Gulf. And you can, I think this is such a small additional profession. You can't do, no doctors can work, no operation can be held without an anesthetist. And you have scarcity in the government hospitals. Can you imagine the health situation in country like India? I'm very worried about that in the future, in the coming days. I'll stop here. Yeah.
Dr. Rajan, I have a follow-up question for you. You just talked about the positive circular migration. So, as a source country, what can we do to, boost positive circular migration? What kind of policies should we have as source countries? Could you please highlight 2 or 3 things that you feel should be done?
No, I think that, you might heard about this Abu Dhabi dialogue, Colombo process. I attended several things. The problem is that, we are projected like the South is like a competitor. Sri Lankan, I was sitting in an office in an embassy in Kuwait. The ambassador was telling me that, we are competitors here. I think this is not true. We are treated, and in the name of we are competitors, Sri Lankan housemaid or Sri Lankan nurses are competing with Southeast Asia like Indonesia, Philippines. They are exploiting us. It's like we are not together. I think this is where we fail. I don't think Colombo process is a great success. I know I was in the IOM office in Colombo process right now handled by IOM in Colombo. I was there a few weeks back. I think this uniting the South itself be a big task. I should not feel a Sri Lankan nurse is a competitor. I should not feel Filipino nurses. We should together and bargain for wages. What is the 2,000 euros in some of the countries? 2,000 euros is what? It's, you look at the cost there. You look at the, we are not telling them. We are talking about 2,000 euros, 3,000 euros, and multiplying with in Sri Lanka currency is completely, that currency value. I think we are not really talking the real money terms. Actually, somebody who is, and I think we need to educate the people. In fact, I would say that we should go to this is what I am planning to do. We should go to colleges, medical colleges, engineering colleges, nursing colleges. You should go and talk to them about migration. You should start somewhere there. Teach the children. Like everybody want to migrate. I think everybody should have a passport. Tell them at the 10th standard, +2, before they go for, even nursing. We should start there. People think it's like a dream. And, some of them are overworking. Some of them are highly stressed nurses. I have seen stressed nurses. If you are working in your own country, it's different than you are working in another country, get your promotion, get things. I think it's very important we unite, Priyanka. I think very important we have to unite together and then understand why should the Indian nurses to be trying to be the best nurse in Germany? No. That should be invested by German government, should invest here, open a college here, you give your syllabus. Hours alpha, then they have to go 1 year, they are wasting their time to learn their trick. Why should they learn our trick? They can go to Australia. Why should they learn German? I think we are being exploited right and left in the name of money. I think somewhere we have to talk about ethics. I think ethics has to come in, because I feel, I used to talk about, land mafia earlier days. Now you have a labor mafia in many countries. They are being taken. This mafia has to be, they are strengthened. And unfortunately, the migrants are not strengthened. We should strengthen our migrants, fair migration, labor rights, all are, some of the places they have not even paid salaries. I was looking at the wage theft during the COVID-19. 30 to 40% people were running without getting salary. Rich countries are not paying our poor countries. People work for salaries. It may be general migration, but even nurses, I don't know how much, are they really getting the salary what they were promised before they left Sri Lanka or Philippines, or what mechanism we have. Of course, Filipino has the strong mechanism. I know that their system, because they do talk about promoting migration face to face. We don't talk. We only talk about facilitating migration. I tell many times the Indian government, you are talking, not rubbish. You are talking something. Actually, you are promoting. You are talking about skill center. You are talking about Ministry of Skills. Skilling for whom? Skilling partly to migrate. So openly be like Filipinos. Facilitate legal, orderly migration. Promote legal, orderly migration. That is the motive of Philippines. We should also talk about not just to facilitate, promote legal, safe, and orderly and fair migration for our citizens.
Thanks a
Our
lot.
citizens.
Thanks a
Yeah.
lot, Dr. Rajan. I completely agree with you. I would like to move to Dr. Benzon, and I would also pose the same question to you. Why do you feel the regional governance around migration has remained so weak in South Asia, Southeast Asia? If
Oh,
you could throw
okay.
some light on that.
Um, yeah. Um, I'm not sure whether I actually agree that the collaboration is weak. Um, in fact, so the Philippines is part of WIPRO, and it's also part of the ASEAN. And very recently, the Philippines initiated a collaboration, a partnership with the Pacific Islands. I know that this is a crisis, not a workforce shortage, health workforce shortage is a crisis, but we can also look at it as an opportunity for us to work together and build each other up. I think that's the perspective that we're taking. So when we talk of collaboration, it has to be authentic, it has to be genuine, it has to be ethical, and it has to be something that actually promotes mutual benefits. Like I mentioned earlier, there are countries that have more capacity in terms of its workforce, but that should not be taken advantage of by those that need this health workforce. So arrangements really have to be uh, uh, the language that we used before was mutually beneficial, but now it really has to be along the lines of co-investments. Um, Also, when we talk of solutions, we can't go to global solutions or regional solutions without fixing at the country level the systems. I shall speak about the Philippines. In the country, we have the national HRH master plan, and this master plan is not only for the health sector. It is something that guides and provides strategic direction for the whole of the country. So we have to be very clear and unambiguous about the direction we want to take when we're talking of health workforce management. So I think that's to be that's basic. Domestically, at the country level, one should have that. The other thing is, I heard Doctor, I think was it Doctor Saroj or Doctor uh, um, I think the
Thank you.
previous speaker spoke of the lack of the paucity of data. So having a master plan is important, but also making sure that data is in place. So the Philippines has the National Health Workforce Registry. I think it's a little late in the ball game. We should have done this like 50 years ago, but we've only launched it recently. But the important thing is we're starting to have our eyes on our workforce to make sure that they are competent, to make sure that we have enough they're adequate, and to make sure whether they're moving because of whether they're mobile, whether they enjoy decent work conditions. So second, the third is we actually have an HRH network, not only from the health sector, but whole of government, whole of society, public sector, private sector, talking together about issues concerning the health workforce. So we cannot go and discuss about global agreements and arrangements without first being really clear about where we want to take our health workforce. So that's the first. The second is for countries who have more in terms of expertise and experience. It's about time that we share resources and expertise. So the Philippines, which country, we're definitely not uh, from the West. But we have experience, we have expertise, and we have reached out. In fact, recently we sent a team of a Philippine medical team to lend support in Tonga, um, uh, almost like a medical mission. We've also started to talk about it, other packages of assistance. So I agree that the collaboration is weak. In fact, uh, it's something that we can define for ourselves as countries. Um, we don't have to just take what's given to us by powers that be. Okay, at the global level, there is the code. There is the code that defines ethical global arrangements for recruitment of health workforce. Now, it's not a perfect instrument, but we, as member states, we are allowed to, in a very orderly and organized fashion, influence the language of the code. Um, so I'm not sure whether I agree that the collaboration is weak. It's not as fast as we want it to be or as effective as we want it, but we're moving slowly and surely. So again, I would say that the health workforce, global health workforce shortage presents itself as a crisis, but also it can be an opportunity for us to work together and learn from each other. Thank you.
Thanks a lot, Dr. Banzon. It was good to know. I will now move to Dr. Saroj, and I would like to hear his opinion on whether he feels that regional governance on migration is weak, or does he also feel it's not that way?
Yeah, I think we should have a useful framework. So there will be several levels at which we could consider at the local level or national level, and then certainly regional and the global level. And I think there is hardly any sort of agreement on this. What's happening is that the more affluent countries are basically calling the shots and doing what they want and taking our human resources at their will, the way they want the human resources to flow into their countries. And you'll see this when they change their visa requirements, and they change periodically, change their point system or their visa qualifications based on their need. And that's been decided by their economists and their governments. So this whole thing that we want individuals to have their rights to migrate, that's fine. But at the same time, we have to realize that the broader picture, that it's being governed elsewhere. And that's where governments should be pushing. And this is why I feel that the discourse should shift not only to the problems we are facing when the migrants go there, but the role played by those governments in this whole process. For example, when we are having when there is migration, we have a huge problem with our services, right? That's one. So it might be just two cardiologists going, but remember, those two cardiologists will be in two hospitals which have only one cardiologist each, which means two hospitals have no cardiologist, no intervention cardiologist, no anesthetist. All right. And that's what is happening. So you are creating holes in our health system by this migration. Then comes the economic impact. So the economic impact is huge. And all this costing is done on recurrent expenditure, right? Where it's standard economics that we should look for the expenditure, the capital costs are not being counted. I mean, we are just looking at the salaries and the electricity and blah, blah, being paid by the universities and calculating the cost for of a graduate. That's not the only cost. There's a huge capital cost. They're using space. There's a huge opportunity cost because another person could have gone there. There's a huge opportunity indirect cost because they're being kept healthy by the state. So there's a huge economic cost, right? Now, when they go overseas, especially the qualified people, they hardly send any remittances. It's the lowest, poorly skilled people who really send remittances to our countries. So perhaps we should be moving towards some sort of taxation system. In fact, we've discussed this point in that article I mentioned, which was published in the International Journal of Planning and Management. That was last year, actually, 2025. So where you have some sort of taxation system which remits some money back to the countries which sent the workers. So all these macro aspects should be considered when we are going for international policy. It should not be just a case of sending people to gain employment and become cogs in a wheel. We are now having a situation where our carers are leaving their parents to go and care for other people's parents elsewhere. And the parents are here without the carers. So I think these have to be worked out. It's not that I'm not against any individual person migrating, because at the end of the day, that person has to be responsible for the family, and that's no issue about that. But I think we have to look at and try to fix this system so that it's a win-win situation at the end of the day. Thank you.
Thanks a lot, Dr. Saroj. I think I'm left with 5 more minutes. So I'll quickly ask all of you to basically suggest 3 actions that we should prioritize if we want to work collectively on this issue. Very, very quick answers from all of you. I'll start with Dr. Banzon. Dr. Banzon, you are on mute.
Okay. I think I think you mentioned it earlier. I think it's important that there has to be clarity where we want to take it. There has to be an agreement as to where the direction would be. We talked about this already. Let's align on what we want to achieve. If we were to really collaborate, but For us sending countries, I think we can bring the conversation to um, ethical co-investment. I think that's first co-investment in production through co-investments in retention through skills building, competitive compensation, career pathways, and even rural deployment. Um, of course, co-investments in migration governance. So I think the keyword for me would be co-investments, alignment in where we want to take this. That's it for me. Thank you very much.
Thanks a lot, Dr. Banson. Dr. Rajan, any three key actions in just that you would like to highlight?
I think one is I agree with Jagannath about the co-investment. In fact, I will not say even co-investment, full investment, not co-investment. We don't need to do anything because we are giving our people to them. So full investment by them. I don't want anybody to go to any country with we put our money. So full investment I want, not the co. The second point I think is that we have to relook at our migration policy. I think migration bill is being debated right now in India. And the third one is that we have to inform, because what happened is migration is not still mainstreamed in our public discourse. I think I agree with Dr. Saroj, because people don't think that it is going to, some people are going, they are making fine, but it is how it is going to affect your society. I think that is not being really documented to people. I think something we can do it as an organization, as an individual, to the public domain. I think public debate has to come. I think we can do the public debate. It will be very great. These are the 3 points I would like to make. Thank you.
Dr. Saroj, would you like to say something?
Yes, thank you. So I think we have to have, as mentioned by the other speakers, we should have clarity on what each country really wants, and certainly is some sort of economic and social costs. We have to value what's happening. It's not just the rupees and cents or dollars, but the huge cost, which can in some sense be monetized, but that's something we have to think of. Second point, I quite agree with Rajan. I think we should be looking at regional cooperation also. Right now, it might not be, these are sort of things which are very sensitive, and certain professions will not want regional, regional movement. But I think with time we should be thinking about a sort of a regional cooperation also on immigration and working in other areas. Now, thirdly, I think we should be looking at global governance. And you see, if our countries don't look at it in that way, others are not going to look at it for us. We have to show the world that this is unethical as to what's happening, for the affluent countries to implicitly encourage workers to move and cause total disruption in health services. So they cannot be exonerated on that. I think that's the sort of thrust we should tell from our governments. Again, I'm not against people migrating on their own choice and in this present system, but it's at the state level. We have to have that that sort of approach. Thank you. Thank you.
Lord, Dr. Saroj, thank you everyone, Dr. Benzon, Dr. Rajan, Dr. Saroj, Dr. Lahiro. It was wonderful speaking to all of you, and I think we have had a very rich discussion. I would like to now open the floor to everyone But I think before that, I think Dr. Rajan has to leave. He has some other prior engagement. So, Dr. Rajan, thanks a lot for joining, and it was really, really helpful and insightful. We look forward to seeing you in future again. Thanks a lot.
Thank you. Thank you so much for I think I had a very interesting members, both Dr. Saroj and Sogana, and also Priyanka and other people, and also the participant. I see 40 plus participant. It's a good thing. So I know I have to attend somewhere. So, but then thank you very much for the meeting, and anyone can get in touch with me. And when I visit next time to Sri Lanka, probably I'll see if I can meet Dr. Saroj and Dr. Lagiru. So thank you very much. Thank you. Bye-bye. Bye-bye.
Thanks a lot. Thanks a lot, Dr.
Thank you.
Rajan.
Bye.
Yes,
Dr.
Priyanka,
Lairu, would you like to
yes.
take the questions?
Yes, I think we have one attendee raising hand. I think we can allow him for the first question. Amir, Sohail, if you can put your question to the panelist.
Yeah, hello. Am I
Yes,
audible?
Amir, we can. Yeah, you're audible. Please go ahead.
My name is Dr. Amir Suhail. I'm assistant professor in Patna University. My question is from all the panelists, especially from India. My question is that India continues to face an acute doctor shortage, especially in rural and underserved areas. And there are thousands of qualified foreign medical graduates who, every year they pass medical, from different universities across the world. So, but they remain underutilized. My question is that what policy and regulatory reforms could you suggest that enable India to effectively utilize this manpower cohort?
Thank you, Professor Amir. Unfortunately, Professor Ranjan just left the meeting, but I think we have a similar context in Sri Lanka, if I'm not mistaken. Professor Saroj, perhaps Professor Saroj can highlight how Sri Lanka has sort of utilized the people who are trained in foreign countries for their basic medical degrees. The system that prevails in Sri Lanka, perhaps we can compare. We will put your question to Professor Ranjan, definitely, Professor Amir. We will come back to you. Unfortunately, he left the meeting for another engagement, but Professor Saroj, yeah, you can.
Yeah, so let me reword the question. Is it how people who have migrated can be of use to the
Yes, migrated in the sense for the medical education, and when they come back, how they can be integrated into system.
Right. I think now talking of Sri Lankan situation, if they have gone out overseas for their training or on leave from the state sector, there is no issue of them coming back and integrating back to the government state sector. You have to remember that the government health sector, for example, it's dominated by the government. The health sector is dominated by the government system. So we have 90 to 95% of all beds are provided by the government. So the private sector is numerically very small, and in the outpatients, maybe 50 to 60% consultations or more in the private sector. So if a person goes and comes back as a specialist, then they can join the state sector. Now, if you either leave on your own accord and come back, then it's a case of working in the private sector, or you can try. Sometimes the universities might take you. So it's if you have come back, or that's if you have gone for training, or if you have gone overseas, not through the official channels, but obtain your specialty and came back. And otherwise, if you work overseas in whatever other capacity, again, you can come back and join the private sector. Now, the issue is if you have left the government sector and gone overseas without obtaining prior approval or leave, you will lose your seniority. So that's the issue. Now, if on the other hand, you have been completely trained overseas, then if you are in the junior categories, you have to sit for a qualifying exam in the states in Sri Lanka, and then enter the government sector. I hope I answered your question.
Yes.
Yeah.
Yes, I think from a Sri Lankan perspective, so you have answered. Professor Amir, as Professor Saroj highlighted, if a medical graduate graduated from a university not from Sri Lanka, from a foreign university, has to sit for a licensing exam in the Sri Lankan state, and if he wishes to join the government or state sector, which almost all in Sri Lanka sort of aspire to, so they have to go through this licensing exam and um, come back to the system. So their services are utilized. But we can definitely sort of highlight your question to Professor Ranjan and get some inferences regarding the Indian situation. Now, we have several other questions from attendees. So one particular sort of a question that has been highlighted several times is what is the situation in emergencies, particularly when you think about the surge capacity of some of the countries. We have seen this trend in the COVID-19 and also in some other sort of global sort of emergencies where the country, source countries are sending people, they are sending people to the countries in West or so-called developed countries to manage their system, particularly during the COVID-19 as well. So how this plays out in the whole sort of discourse in health migration, particularly in emergencies and in instances where the surge capacity is required from these host countries. Dr. Joanna and also Professor Saroj, if you can sort of highlight.
Well, shall I try?
Yes,
Is
yes.
not there right now.
Yes.
So I think in Sri Lankan point of view, we didn't have such an instance of people suddenly being required to go and leaving their stations. I mean, government to government, yes. There might be short-term assignments, like there are few who go to Sudan through the UN system. But those are official ones. But otherwise, there is no real provision as far as I know. Yeah, thanks.
Yeah. Dr. Benson, if you can highlight whether there have been any instances where during emergencies the migration patterns have changed.
Oh, okay. In the Philippines, we have during the COVID, there was a time where we actually had a moratorium. We had to impose a moratorium on migration. But as soon as COVID was declared over, we reviewed the mission critical positions, which were the ones which we had a moratorium for. And currently, we don't have a moratorium on that. But just to also say that I mentioned the National HRH Master Plan, and we have a bureau which I head. It's the HHRDB, which is the Health Human Resource Development Bureau, which is a peacetime sort of a agency. We have a special agency for health emergencies that actually make sure that we have teams that are able to respond to emergencies, and they actually develop teams that can respond to other countries in terms of emergencies. Thank you.
Thank you, Dr. Another question that has been sort of repeated in the chat box, I think, whether there is like, we also see that like there is a mismatch between the production of healthcare professionals and also the infrastructure development in case of health. So when there is no such infrastructure to accommodate the number of healthcare workers produced in the country, there will be almost automatically there will be some migration. So several of the attendees have asked whether that is the case in other countries like India, and also are we producing more that we cannot accommodate these people inside the system, that letting them to sort of to choose other avenues for their professions. Is that the case in Philippines, Dr. Joanna?
There was a time that that was the case, but we had an intervention for it. Shortage was a problem. And to respond to this shortage, we created the free service scholarship program that actually sent doctors to school. And after sending them to school, we required them upon entry to the medical school, they had to sign a contract that they were going to have return service. So after they graduate, pass the licensure, we offer them jobs. For 3 years, they are sent to the barrios or the villages or the underserved uh, um parts of the country. And after they've served, they actually can have options. They can do residency. Um, they can go to academe. They can serve in local government units. We've expanded that program, and now it's called the Medical Scholarship and Return Service Program. And we're not the challenge now is to provide jobs for them, right? Or opportunities for them to serve. And so instead of just sending them to the villages, we have opened other streams of service. Like I mentioned, it used to be that they had to go to the villages first. Now they have 6 other streams that includes academe, research, residency, and all sorts. And that as long as they are in the sector, they're able to serve. And if they opt to go and migrate after they've served their return service obligations, that's also fine, because then the past years that they served would have allowed us to produce the replacement in the country. So it really has to be just systematic and strategic. Thank you.
Thank you. Thank you for highlighting that, Dr. John. A very interesting system. Professor Saroj, in a Sri Lankan perspective, now from a Sri Lankan perspective, we are hearing the news that we can't afford giving internship for more doctors in the coming years. So what will be the solution? Because invariably they will migrate if they pass out, and there will be no sort of state structure to accommodate them in Sri Lanka.
I think you see, it's very difficult. In a sense, it's very difficult to have such very rigid match between the needs, the infrastructure, and the output. It's almost difficult in a complex system like this. Because now, what is adequate? Is it the current available cadre positions? Or are we going to say it's adequate only when we have the ratio which is of doctor to patients seen in the West? When you say, assume that you are using some other criterion like the rate of doctors to patients in the West, what's the justification? I mean, what's the demographic justification? What's the epidemiological justification? So in a sense, I really don't have an answer to this, but in a sense, it's almost impossible to find this ideal. We'll always be moving, juggling around, trying to find the best fit. But to answer your question, are we overproducing? Well, we've had this idea that we are overproducing for several years, and we're probably not. But now there's another important aspect, because CRO in the Lancet issue of 2024, I think, Lancet of Southeast Asia region, the human resources for health in the Southeast Asian region of WHO has been the flagship, and one of the flagships. So they found that we have really produced large numbers, but there's now a problem about quality, right? So there is always just the numbers wouldn't really be the question. So which means we will almost never know what is the ideal quality plus quantity wise, right? So yeah.
Thank you, sir. So before handing over to Priyanka, may I put another one question, because like this has been sort of put to the chat box as well. So regarding this devaluation of credentials, I think that is a real problem that we are witnessing in South Asian perspective. Nurses going for caregiver jobs and so forth, and also in a very specialized component. Also, some of the specialties, for example, the surgical and the internal medicine specialties, getting the lion's share of the specialist training. which is provided by the state, whereas unpaid sort of specialist training for, say, the public health professionals who are working in the nutrition sector, and professionals who are working in the palliative sector. So they are provided training slots without due sort of recognition for their payments and so forth. Professor Saruj, how you can navigate this issue, like the devaluation of, I will come back to you, Dr. Benson, as well. What are the options that we have for this devaluation of credentials, and also, say, the differential treatment on specialties, the discipline-wise?
Well, I think, I mean, in this, there is no hard and fast rule, because, for example, if we want to train a vascular surgeon or a neurosurgeon, the sort of training which we require is going to be totally different to a person who is going to be trained as in another category or in the medical specialty itself, for example, general physician, right? So there is, it should be according to the need. Sri Lankan situation again has been distorted because we are sending our doctors mandatory 1-year training overseas. And that was actually a compromise for a situation which was there in the 1970s, because prior to that, all postgraduate training and exams were done by the British professional colleges. So as a result, when we wanted to have our own postgraduate exams, the government had discussions with the unions and came up with a compromise that, okay, we'll do all the postgraduate training here, but we will allow you to go on a government-sponsored scholarship for 1 year to be trained overseas. So that's been going on for now almost close to 50 years. So you see, it's all depends on the context of the country and the speciality. There's no hard and fast rule.
Right.
We have to find our own solutions for the different ones. There can't be a general rule.
Yeah. Dr. Benson, regarding the devaluation of credentials, any sort of way out on that, like the nurses being devalued to be caregivers? So any best practices from Philippines?
Yes, thank you very much. I feel very strongly about this. The best practice I would say is that, as I mentioned earlier, we have a whole of government collaboration. So although we have a department on migrant work, the Department of Health, for example, myself, sitting as a representative, has a say in the G2G, government to government recruitment. So a very clear example, we were speaking to a country, a European country that wanted to recruit nurses to be to give care, but also to fill out social health insurance forms, to go visit homes, and it's more like a caregiver function. And we said, no, we do not allow that. As a matter of policy, all our health workers are practice ready. So our doctors will be doctors in your country. They can be doctors, they can function. They will not be clinic managers. Our nurses, they will be nurses in your country if you want to recruit them. They will not be caregivers. Our dentists will not be dental hygienists. So we were very clear about that. But I think what we want to highlight is that the Department of Health, or the Health Human Resources Development Bureau, is given a seat at the table during negotiations. We are able to give inputs. So the other thing that I'd like to highlight is it's very important to have bilateral labor agreements, because this is where the negotiation happens. And in this particular country that we had a negotiation with, we actually came to an agreement, and instead of de-skilling the nurses, we upskilled caregivers, and then they will get better pay. They will be given training to do the work that's needed for social health caregivers.
Yes.
So it's important that the country, the source country, is very clear about the non-negotiables that it has. So for us, it's a no-no. The next thing is before we go into a memorandum of agreement, the Department of Health, for example, has to concur. So if our provisions, our required provisions are not met, then we will not sign, and the recruitment will not happen. Thank you.
Thank you, Dr. John. I think very interesting that I think the strong government policy and also the bilateral agreements between the countries, that is the way forward, I think. Then thank you very much. Over to you, Priyanka, for the last step.
Thank you, Dr. Lahiru. We have few questions from our team members. Dr. Neeti Rao, who's fellow at CSEP, and she's the one who initiated this webinar. So she is asking us, like she's posing two questions. Of the first question is for Dr. Benzon. Dr. Benzon, you have talked about the HRH master plan in Philippines, and in the earlier webinar which we had, there also you talked about it. So, do you also consider team-based HRH requirements, like apart from the usual uh, health profession to population ratio? So, do you also consider team-based requirements?
I'm afraid I don't understand the question. Uh, or team-based HRH requirements. Are we talking about standards or?
Yes, yes.
We don't have standards, HRH standards for teams. Rather than we have standards for specific cadre, and we adopt the standards that's been set by the SDGs. Is this a question? I'm not sure if I got the question right.
Okay, I think
Is that
the
the
question
question?
is around standards. If it is not, Niti, please do clear it up. There is another question, because most of these countries that we are talking about are also taking universal health coverage reforms, and there are massive investments which should be happening in these countries. And some countries like Sri Lanka has already been doing it for a very long time. Even India is on that road. So do you feel that these UHC reforms have been able to help sort of retain health work professional in the country because of these reforms coming up? So what's the correlation between the two, if there is any at all?
UHC and migration.
Yeah.
Is that the question? I'm afraid I don't have data uh, on this connection, whether it's actually pushing people to leave or pushing people to stay, keeping people in. But what UHC has done is actually allowing us to have data that we didn't have before. So knowing where we are in terms of decent work conditions, for example, the UHC in the Philippines also has a special health fund, and that provides great, amazing possibilities for us to support local government units that are not able to pay for the full salary, for example, for lack of funds for its health workers, or hire more people. So there is that possibility. The special health fund brought about by the universal health care policy in the Philippines presents that possibility for us. But as it relates to migration, I'm not sure whether there is a connection. But definitely, it will improve working conditions, because then it will allow us to top up for incentives for the health workers, the Magna Carta benefits, for example. So I would say that's a positive effect for health workforce management. Thank you.
Thanks a lot, Dr. Banzon. There's one more question. So you have talked about a South-South collaboration with a Pacific Island country. Uh, so are there any other such formal or informal partnerships with other countries, if you can possibly tell us about those that Philippines has with
Yes.
these countries?
So this initiative is actually called the Philippine Pacific Health Initiative. And whilst we have started with clinical support, lending actual medical support, there are possibilities for sharing of knowledge in terms of health workforce management, teaching, for example, other countries in the Pacific how to do workforce planning, or WISN, or HRH master planning, or building an HRH network. Because now we have experience. We've already made the mistakes, and we have insights. So it's not just a matter of providing actual health service providers and doing medical missions, specialists and nurses, and but also actually helping to strengthen the health system of the Pacific Islands, the little Pacific Islands. But similar to that, we have an understanding and an agreement with Jamaica. And the plan for Jamaica is to bring experts, nurses from the Philippines, bring them to Jamaica and teach their nurses there on specific clinical areas. There's also that's just one part. The other part is online courses. Then their nurses come here, practice in our government hospital, mentored by Filipino nurses. So a lot of models. We call it a menu of packages, and I think that's something that South-South collaborations should consider and explore. Thank you.
Thank you, Dr. Banzo. It's wonderful to know about the Jamaica example. I'll now come back to Dr. Saroj. Dr. Saroj, one of our attendees asking about the governance institutions around migration. So he or she is asking whether WHO or ASEAN, are they well placed to help govern HRH migration? So what are their roles, and to what extent have they been helpful?
Well, I am not specifically an expert in this area, but in this particular governance issue, the question is raising. But I know WHO has a code of ethics. I don't know about ASEAN. I know SAARC is not functional now, so we are not in ASEAN, we are in SAARC, and SAARC is not functional now. And I know that all these have got disrupted during the past year or two with the changes in the global order, the world economic order, as it were, because rules are changing, visa restrictions are changing, work permits are changing, and so on. But in the long term, I think as countries, we should be looking at some sort of fair way of migration. See, so many years ago, when the World Trade Organization came in, also people really were wondering whether we could ever have an organization which will arbitrate and help facilitate global trade. So similarly, this is a long shot. But unless we, the affected countries, start to discuss about these, we will not get the agenda, get it even on the agenda. You see, when you go for meetings, the agenda is about how migrants can integrate into those recipient countries. It's not about how migration is destroying a health service and how do we try to sort that out, or how do we try to mitigate that. So we have to set the global agenda or push for prioritizing these issues so that migration of health workers especially comes on a fairer sort of system. There will never be 100% agreement, and there will always be issues which will come up. But let's move towards that. Let's put it on the agenda and move towards a fairer global migration policy on health. Yeah. Thank you.
Thanks a lot, Dr. Saroj. I think we are done with all our questions. I would quickly wrap up this whole session. So we had a very enriching discussion on like what are the problems, what needs to be done. So from Dr. Rajan, I'm taking up the points that there is no data on movement of health workforce, and it's very, very important for India to, start working on that front. We have some examples from Philippines, and maybe we can learn from there. Similarly, we also need to look at the entire supply chain. It's not just about workforce moving from one country to another. People are moving for studies and those things. So you need to start looking at the whole supply chain. Uh, then about what can be done regionally. I think there are a lot of possibilities, and Dr. Benzon has already pointed out 2, 3 examples coming up from a Pacific Island country, Jamaica. So all we need is to have more clarity, ethical or full co-investment, and I think that's the way forward. Uh, for us, it was really an enriching discussion. We would like to close the session now. I would just want to know, I would just want to let the audience know that we are coming up with our next webinar in the month of February, which is going to be on climate change and health workforce competencies. What kind of skills are required by health workforce to deal with health impacts of climate change? I hope we'll soon be sending out the invitations. I hope all of you are going to join us again. Thank you so much. If you have any queries, you can always write us to at the following email address. I'm just going to put that in the chat box. I'm just going to put the website link as well. Here it is. Thanks a lot, everyone. Thanks, Dr. Saroj, Dr. Benzon, for your time. Thank you, Dr. Lahiru, for
Thank you.
co-hosting this. Thanks a lot.
Thank you very much.
Thank
Thanks,
you.
everyone.
Bye. Thank you.
Thank you so much. Have a
Thank
great
you.
day. Bye bye.
Nice
You
meeting all
too.
of you.
Yeah.
Nice meeting you.